Good afternoon, and thank you for the introduction. Sorry for this delay, but I just have to make sure that all the videos will play. That's why I opted for this. So the question is supra-annular TAVR devices, and what are the advantages and disadvantages, disclosures, the EHR team. So thinking about a supra-annular versus annular design, one wonders if it makes any difference. And some sections that you can put some thought in are these: the effective orifice area and patient prosthesis mismatch, if there is any effect of the design on this factor, leaflet thrombosis, if there is any difference, the durability of the valves, future valve requirements, and coronary access. So these two designs, we have to think if it makes any difference. So the maximum area of the annulus is always something that we're looking forward, because the larger the annulus, the larger the benefit. And among different schemes, the circle is the one that always gives you the larger area when it moves from oval to circle and retaining the same perimeter. So we're looking for a circular deployment if possible, and when we have a balloon expandable valve like the Sapien, we have this in 98% of the cases. So at the end of the implantation, we have a circular alignment. With the self-expanding Evolute core valve, the design, this study was with core valve, they found that after implantation, we had circularity only at 13% at the inflow of the valve, and at the level of the annulus, this circularity was going up to 33%. So we have to balance in a way the supra-annular design with the circularity. So when you move supra-annulary with this device, you lose some of the circularity, and I think this has to do with the radial strength between the two metal compositions, like Dr. Kasel highlighted earlier. And when you lose circularity and you get an oval in prosthesis, then the stresses on the leaflets also become different, they're altered, and this may predispose for worsening durability of the valves. So these are some examples of how you have a very eccentric, very oval annulus when you have type 0, true biventricular bileaflet with a lot of calcium, like this case. We tried first with Evolute R, but we couldn't reach that area, so fortunately we finished with a Sapien valve, and with the very good result, it retained the circularity there. So it was a good option, and we know from the latest data between Sapien 3 and Evolute R, with Sapien 3 in bicuspid valves, we get less paravalvular leak and less likelihood to need a second valve at the expense of a slightly higher annular rupture if we're not prepared well. And this is the other end of the spectrum. When we have a lot of calcium, we're afraid of circularity after implantation, but we cannot oversight this calcium and forget about it. So this is why we opted first for valvuloplasty with a really undersized balloon, small balloon, and then for a self-expanding Evolute valve that you can see here. It's not circular, clearly. You can see it's like a triangle at the inflow. But who wants to post-dilate on this annulus? I wouldn't. So we didn't, and we have a very good hemodynamic results. So these two examples, they gives you the sense about the balance decision you have to make in these cases between retention of circularity down there or safety when you have a lot of calcium. And what about the effective orifice area? So this is the Partner 3 study, the results on the orifice area with the SAPIEN valve, an annular design. So it went to from 0.8 to 1.7, which as all these years we have seen this difference between SAPIEN valves and self-expanding Medtronic valves. So the low-risk trial, the same type of population. With this valve, we had a 2.2 effective orifice area. In SART-AVI, again, we had a 2.2 effective orifice area. So the same population. And when we see the baseline echo characteristics of the Partner 3 study, we see that the annulus perimeter on MSCT was 78, between 78 and 79. So this difference, and in the SART-AVI MSCT, the annulus perimeter was exactly the same, 78.1. I don't have the data from the low risk, but it seems that they are the same population. So this difference in the effective orifice area cannot be explained on baseline differences between the populations. They are the same population, but at the end, we consistently get a larger effective orifice area with the Medtronic valves compared to the SAPIEN valves. So this, it's the obvious explanation is that we always oversize the self-expanding valves, as you can see on the tables of uses here. So for a 23 annulus, we use a 23 SAPIEN valve, but we use a 26 Evolut valve if we opt for the Medtronic valve. So this is the obvious explanation. We put larger valves in the same size, so this gives us a larger effective orifice area. But all these data are coming from non-randomized comparisons between the two. The only randomized comparison between the two comes from the older choice trial from Germany, where they randomized 250 patients between SAPIEN and Evolut valves, and you can see the dimensions of the diameters were exactly the same, no difference, and the effective orifice area after implantations of the valves there was also exactly the same. So there was no difference in this randomized trial between the effective orifice you get at the end. So it with the same baseline anatomy. So it may also have to do with the selection of the valve, and we don't really know. What we really know is also there is a difference in the PPM, patient prosthesis mismatch, between the recently published trials. So in the Evolut low risk, if you go down here, you'll see in the TAVR group, the moderate PPM only 10% and severe 1%. And if you go in the Partner 3 study, you'll see moderate PPM in the TAVR group in 53% instead of 10%, and severe PPM in 8%. So this is a huge difference between these two devices in PPM incidence. But then if you move to observe the numbers in the surgical arms, you'll see something strange there. You'll see that there's also a huge difference there. And so I start to question the big difference between the TAVR groups. Certainly some of it has to do with other factors, but certainly it's real because the difference is really huge. And moving to leaflet thrombosis and durability, does it make any difference between the two designs? Well, we know that the leaflet thrombosis and accumulation of clots starts at the basis of the leaflets and then gradually extends to the tips of the leaflets. And here is typical MSCT appearance of this accumulation of thrombus, very little at the base, and at follow-up it becomes larger and extends, and again very little, almost normal here, and you see the thickening there in the follow-up. So what are the forces that close the leaflets and what type of vortices are created there. So you see here an MRI reproduction of the velocity mapping, and you see, keep at the diastolic phase, the colors there. You see that the colors are blue all over the area of the aortic annulus. So there is no difference in the closing force wherever you are in the aortic annulus. And see another representation from MRI, again, how the vortices return back on diastole, and they're the same color, the same velocity everywhere. So you can see that these vortices come from outside, from the periphery of the annulus, and they close the leaflets moving to the center. So all the forces that are coming here, the leaflets, they close it to the center. And when we put an annular valve like SAPIEN, then we create a cage here because we have the native leaflet outside. So all these vortices that are coming from outside of this cage cannot be transferred, cannot move and be used to close the leaflets. So the vortices that closing the leaflets inside this cage are limited. And in the supra-annular design, things are a little different because the annulus moves higher, so all these vortices are still there and going to help closing the leaflets of Medtronic valve. And exactly this is the change in the new space. As you can see, the Neo-sinus that it's created with the SAPIEN valve. So all this area of the leaflet is not affected by forces outside of the cage, and when we implant a Medtronic valve, this area that is not affected by pressures outside is much less. Of course, this depends also on the height of the device. So if you position the Medtronic valve lower, then this area becomes larger. The higher you go, the smaller that area. So it appears that this may have a practical and a clinical effect, because from this study we see that the leaflet thrombosis incidence overall it was higher in the annular designs valves compared to the supra-annular, and that appeared to be significant. Of course, this is observational, non-randomized data, but nevertheless, we have to make a comment because it appears that the two designs have a difference on the incidence of leaflet thrombosis. Moving to the transformations that we have in the aortic root after valve-in-valve implantation, moving to the valve-in-valve, we see that when we implant SAPIEN valve in another SAPIEN, nothing changes within the aortic root. When you implant a second Medtronic valve in another Medtronic valve, so you have to move a little higher, but the leaflets of the first Medtronic valve, because it's supra-annular, they're really higher. So the new cage that is created and isolating the leaflets of the latest valve from the forces outside, it's going really higher. So in the first case, when we have valve-in-valve with a SAPIEN, within a SAPIEN or within a core valve, nothing happens. But when we have a supra-annular valve, when we going to need to have a valve-in-valve procedure in the future, this is going to considerably alter the anatomy of the aortic root. So if the anatomy of the aortic root is small, you can imagine that it may isolate the sinus of Valsalva and interrupts the return of blood there, so we may have problems with coronary. So this is something we have to think carefully about when we're using our first valve, because it may have an effect, especially in younger patients that are going to need a second implantation for sure in the future. Of course, what comes first is the safety of the procedure, because you need to have an alive patient after 10 years to need a second procedure. So the priority is the safety of the first procedure, but these things should also come into mind, and certainly think early about the future. So here you see a valve-in-valve, a TAVI in TAVI, in a degenerated evolute. It was a patient with renal failure, so if I remember correctly, it came back after 4 or 5 years with restenosis, and you see how we opted for Sapien within the evolute, because this also gives you less metal, it keeps the one layer of metal, so access to the coronaries doesn't really change when you implant a Sapien within the evolute, and post-dilatation to achieve a larger diameter, and this was our final result. And this is another case of valve-in-valve. This actually was a lady that needed, it is the old core valve that needed to have 2 core valves at the initial implantation, because the first was really low, and it came after many years. I think the first implantation was in 2012 with restenosis, and it was really, really tight. You see the balloon, it was difficult to get it up there, and we needed to do multiple balloon inflation to crack the calcium and the degenerated leaflets of the evolute, and then we implanted TAVI in TAVI, a Sapien within 2 evolute valves, and this was the final result that was very good. And you can see the space there, that we still have access to the coronaries if needed in the future. And finally, this is the first implantation. No, the slides were, this was the initial procedure. I showed you how the first valve was deep, and then we needed to put the second, so it was reversed. And finally, a valve-in-valve in a Sapien valve, again a patient on hemodialysis that had an early degeneration and came back, and we positioned a Sapien within Sapien. So this is the case that nothing really changes in the anatomy there with the Sapien valve. I'll go through this coronary anatomy access in the future very quickly, because it was an issue of an earlier talk, but certainly you need to know your valve sizes everywhere very well, and also where is the skirt and where are the tabs. The C-tab is usually in front of the coronary sinus, but not in the left main, but not always. It's intended to be there, and opposite to that tab, the C-tab, it's always a connection of the leaflet, so there is no way, if that is in front of one coronary, to get there. So you should approach that coronary from this area of the cells that are the closest to that area, and also the height issues. And we can use a pre-coronary intervention coronary angiography to know the anatomy exactly, to try and find the cell that we're going to end. So it's a lot of work that you need to do in these patients when we have to go to do coronary angiography or coronary angioplasty. And in this case, a pre-procedure CT scan will be very helpful. And actually, there are guidelines from the paper mentioned earlier many times about how to approach the 2 different types of valves. Here is the exact design of the Sapien valve. The sizes, the upper cells, the large ones, are free of the skirt, and the lower have the skirt. So there are guidelines how to approach them. And here you see one of our cases that we needed to check the coronaries, and we didn't have a real problem with the left main, but we had a real problem to engage the right coronary artery. Fortunately, there was no problem, so we didn't have to go in and to do an angioplasty. And this is another case that we had to access the right coronary artery. There was no way to get into the right coronary artery. It was in front of the top of the skirt. Fortunately, that coronary artery was small and non-dominant, so we didn't really care. And then we had to go into the left main. It wasn't so easy, but we managed to go because there was a lesion, as you can see here, in the circumflex, the dominant circumflex artery, that we proceeded with successful coronary angioplasty. And finishing with the two valves that we also use, the portico valve, that it's not a supra-annular, although self-expanding. It's an annular design that's self-expanding. So you can make your own conclusions about all the issues I mentioned earlier about the circularity. It's going to take a self-expanding valve that is not supra-annular, and about the access to the coronaries with this design that actually has a larger height of the skirt compared to the other annular design, which is Edwards. So here we have 26 maximum compared to the 11 that is the Edwards design. And finally, the accurate Neo, which is supra-annular. The stand height is not, and the skirt height is similar to the Sapien. It's not larger, but what is really higher is the top of the leaflet. The top of the leaflets go up to 30 millimeters from the annulus, which means if you have to go in for a valve in the future, you're going to create a cage isolating your native leaflets up to 3 centimeters from the bottom of this valve. Thank you.